The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. We are gathered here for the next episode of TMD Demystified, and I am Tony Urbanic. I have a very interesting episode today, I would hope, and I hope I can keep your attention for 25 or 30 minutes and talk about what I learned using the Urbanic device and protocol for the past 12 years. I have pretty much covered in this series of podcast episodes, which we are now around episode 93, I believe, all the technical clinical features at one point or another. And I'm pretty much left now with covering the general nature of TMD itself, where we are with this issue, and what I've experienced on confronting this over the past 12 years. Hasn't been easy, hasn't been nice. It has been very difficult. It's been very rewarding. I've commented so much on that. Treating these patients is extremely rewarding. It is very frustrating to see how this problem has been handled by my colleagues in both medicine and dentistry. And I have only felt that I've made some contribution toward it. At this point in time, I know that we have a solution to the problem. May not be the only solution. It may not be the ultimate solution, but we have a solution to the problem where I know my dental colleagues do not have the solution. I can say with certainty, my surgical colleagues do not have the solution. I can say with certainty my general dental colleagues do not have a solution when they apply night guards and other modalities that are not effective, and that they continue to use knowing they're not effective, which is frustrating. But I see it all the time. So we're going to talk about that kind of thing. We're just going to be open about it. Again, I leave myself open for criticism. That is fine. I know that I can be criticized. It's interesting, over this long period of time, now literally approaching 2 years of weekly episodes, I have not received a single criticism on this podcast site. Not a single criticism, not a single comment. And I know people are reading them. Some of the episodes are extremely well viewed. I pay attention. Actually, I just looked at the most viewed episode has received 159 views on the Urbanic device and how the protocol is used, the device and how the protocol is used. But many of the episodes are viewed 50, 60, 70 times. And a lot of those viewers, I'm certain, have thoughts or comments, but I have not received one. I certainly haven't received a criticism. Nobody has ever emailed me, commented on anything that I've said so far. I've tried to be very factual, and we're going to continue to do that. All I'm saying is that if you want to criticize me, I'm open for it. I can discuss it. I can show the facts. So that brings me to the first part of what I'd like to talk about. I mentioned this on the last episode, but actually, I'm going to talk about it again. I was picking up my laundry now 2 weeks ago, and I drove next to a car who was also picking up his laundry, and he had 2 bumper stickers on the back of his car. The first one I already mentioned in prior episode, but I'm going to talk about it again. And then he had a second bumper sticker, and I stood there and read those bumper stickers over, and I literally laughed. And before I left, I had to shake the gentleman's hand for having both of these bumper stickers on the back of his car. The first one said that I already made a comment on a previous episode, was a very simple sticker. It said, "Make facts count again." Make facts count again. And the other one was, and I liked even more, don't believe everything you think. And I guess I was drawn to those so much, not only because maybe my personality and my background and, my interest in confronting things that don't seem to be right or handled correctly, or let's just call it nonsense. In our world, we see a lot of nonsense, and I'm not going to go down that rabbit hole. But frankly, we see a lot of this nonsense, tremendous amount of this nonsense when it comes to diagnosing, treating, understanding TMD. And that's what I've been talking about for almost 2 years now. But both of those statements on a bumper sticker have meaning to me. Don't believe everything you think, and make facts count again. Now, I have been accused in a different venue, not online, but in person, of focusing on anecdotal statements or information. And I know the definition of an anecdote, but this comes from a professor type, basically an arrogant professor type, who said without a study, what I have to say is meaningless. I disagree. A study is nothing more than a series of anecdotes put together and then evaluated. A series of anecdotes placed together and then evaluated statistically. That's what peer review is all about. Actually, it's about statistics, and what's been stated about statistics. And I've quoted that quote before. But we do have a study, I just mentioned, we do have a very good independent university study showing that the results of the Urbanic device and protocol are through the roof. Patient satisfaction is above 85%, and statistically we show that we get routinely success in diminishing symptoms between 90 and 95% of patients who actually follow the protocol. That has to be limited with patients that follow the protocol, because you have to extract or remove patients who don't follow the protocol. That's why the protocol is so important. The simplicity is unloading the joint by disoccluding the posterior teeth long enough according to protocol, make the inflammation go away. That's the simplicity of it. But in any case, so those 2 statements, I think, apply to very much to what I learned using the Urbanic device and protocol over the past 11 to 12 years. So let's go through. I have a series of points I'd like to make about that. And I'm basically pulling it together from multiple other positions, episodes, but kind of putting it all together as to really what I have learned. And I have to admit, as a oral and maxillofacial surgeon, focused on just what the textbook said to do and the Congress has said to do, and what my other colleagues, especially in the academic world, said to do about treating temporomandibular joint problems surgically. I was very naive. Because I believed that they knew what the heck they were talking about. And it has been shown, for sure, I don't have to go into deep, you can't hardly find an oral or maxillofacial surgeon anymore who wants anything to do with TMD, treating TMD, with the exception of a very few who the only thing that's really left to do when it gets serious enough is to do a total joint replacement. And the other modalities, frankly, including use of arthroscopes, which I commented, I've done 1,000 arthroscopic surgeries are pretty much useless. Within a year or two, a patient will be back in your office and they'll be complaining of symptoms again. So I was very naive. I admit it. I have a long series of experience using every type, applying every type of surgical treatment for TMD, which is why finally I gave up and I said, I'm not going to treat TMD surgically anymore. And I went off on a different tangent and decided as I was going to see if I could figure out what was really going on. And actually didn't take very long once I actually started talking to the patients. And that's another history I won't go in. It's in the episodes on this podcast. But here's the points I want to make. What have I learned? What I didn't know that now I know? Number one, TMD is a huge problem. Huge problem. This quote studies, and there are literally they're more than hundreds. There are thousands of TMD studies. Many of them state what the incidence of TMD is, and they state anywhere between 15% and 30%. I think the latest statistic that I was quoted from the National Institute of Health was in the range of 20%. Totally disagree. Those percentage points are the patients who have been diagnosed with TMD. The problem is a huge number of people, especially women, who have TMD that are undiagnosed and that have misdiagnosed with diagnoses such as migraine headaches, fibromyalgia, myofascial pain syndrome, and Meniere's disease, constant ear aches, ear infections. We've talked about that many times, but it's a huge problem. It really runs close to 50% of the female population. And I did my own study, offhanded study, where I went into multiple offices and presented materials years and years ago. And I'd always ask, what percentage of you ladies have one or more of these symptoms currently? And generally 45 to 50% of the hands went up when you went down the symptom list of TMD: headache, earache, frequent or recurring headache, earache, jaw pain, neck pain, tinnitus, subjective hearing loss, vertigo, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of locking. That even excludes the noises, clicking, popping. That is a sign, not a symptom. But the symptoms are listed, and at least 45 to 50% of the hands went up, whether I was talking to a room with 5 females or 25 females. That indicated to me that it's a very big problem. So, and it is a very big unsolved problem, because except for certain locations, especially here in Middle Tennessee, where we have a huge following of referral sources sent in for our services, huge following. It's now over 800 referral sources. In other parts of the country, they still do not know that these patients are being misdiagnosed all the time. The second thing I wasn't aware of, and I knew that it was a problem, and I knew that as a surgeon years ago, I had a growing list and line of patients, again, primarily females, who came to our office and referred to our office because I was known as the TMJ surgeon in Nashville for quite some time. These patients now, I know they go from doctor to doctor to doctor continuously. It is not unusual for me to be talking to a patient and find out that she has been looking for help for 20, 30 years or longer, 40 years. They are frustrated. I had no idea how frustrated these people were. I had no idea how many doctors that they had seen before they came to see me. It is amazing to get, actually, when you sit and listen to the patient's history, how many types of practitioners, healthcare providers that they've seen, on the numbers that they've seen. And you only learn that by actually sitting down there and listening, rather than, bringing a patient in and telling them, doing your exam, getting your history down as far as your symptoms go, doing your exam, whatever that's going to be, to diagnose the TMD. And then you get on with it, but you don't really listen to the patient's full history, and they want to tell you. They go on for years and years. I had one come in again just yesterday who had been going around for 30 years. And again, next point is the problem is misdiagnosed constantly, especially by our medical colleagues. The misdiagnosis of earaches, the misdiagnosis of upper back, shoulder pain, neck pain, constantly misdiagnosed as something else other than TMD. We see so much of it. It is just amazing. And I definitely learned to focus on the misdiagnosis of TMD. My medical colleagues are not dumb. They are a group of very smart people, and they just don't know because they are not aware of how to diagnose TMD or even look at it on their differential diagnosis list. But that is changing here in Middle Tennessee for sure. The other thing I really learned, and that is how doctors, especially dentists, are afraid of treating TMD because they think it's so difficult, so it's complicated. They've learned it, they've heard it. It's been drilled into them since dental school that the TMJ itself is complicated joint, which is not true. Absolutely not true. It operates like any other joint in the body. It is in a different place, obviously. It's in a different place. It's not in your elbow. It's not in your hip. It's not in your knee. It's in the side of your head. But it operates like any other joint. And because they have been schooled that it is a complicated system and is a complicated problem, and because, granted, no one has found a reasonable solution, all that they've seen is a lot of conflicting information and things that they know are not effective and don't work, and that's why they're afraid, literally afraid to treat it, which is unfortunate because, frankly, you have to have some dental knowledge to treat this problem. Going through medical school, you're not going to learn it. I was asked to talk to my medical class about dentistry, and they gave me 1 hour to talk about dentistry. That's about how much dentistry that Vanderbilt University School of Medicine makes available to their medical class. And maybe I was lucky enough because I was a dentist in the medical class, and that's why I was asked to do it. Maybe the next year there wasn't a dentist, so they didn't get any instruction. So don't be afraid to treat TMD, but I learned that my colleagues are afraid of it. There's no reason to be afraid of it. And that brings out the complacency about it. There's fear, and then there's complacency, and it's two different things. Complacency originates because doctors do what they know how to do. Well, that's okay. I agree with that. But there are so few doctors who actually treat TMD successfully. There are a few, quote, what I call TMD gurus, who use very complicated methods, want to make it complicated in front of their colleagues, use complicated diagnostic criteria and examinations that don't have anything to do with diagnosing inflammation within the temporomandibular joint, where it all arises from. And they want to make it complicated, but it isn't. But it creates the complacency from the other dental establishment doctors who stick with their, usual bread and butter crowns, bridges, and dental implants and extractions. And it doesn't serve the purpose of actually solving these problems to the huge number of people, women, who need the service and are looking for the service and are frustrated because they don't have an answer. It's very, very true that in science, you can gauge how successful a problem has been solved by the number of studies that apply to that problem. The fewer studies, the more is known about it. The more studies, the less is known about it. And we have more than needed thousands and thousands of studies regarding the temporomandibular joint, which indicates what I tell you today is that the history of TMD is not being good. We have, up until now, have really not solved the problem. And I encourage you, I'm not the only one who actually can say that inflammation is an important part of this problem. I emphasize strongly that that is the problem. And if you can solve inflammation within the temporomandibular joint, you have solved TMD. If you have a better way of solving inflammation within the temporomandibular joint than unloading the temporomandibular joint, I encourage you to follow that path. But right now, the best way I have found and know of to decrease inflammation within the temporomandibular joint is unloading the joint using a very simple device that disoccludes the posterior teeth under proper protocol. Once you decrease the inflammation, the symptoms are gone. Let's devote this same logic to any other joint in the body, but let's just say a knee problem. Your knee hurts, not because you have bone loss. Your knee hurts because the knee is inflamed. And of course, inflammation over a long period of time can cause bone loss, but the pain itself is caused by inflammation within the joint. And if you decline any kind of knee reconstruction or knee injection, the orthopedic surgeon will give you a set of crutches and say, get off the knee. I promise you, your pain will go away. And that is a fact. A set of crutches will take the inflammation down, which will take the pain down and the other symptoms down. So a little logic cranked into the concept of inflammation within this joint creates all the symptoms is a fact. Which is a fact. It's not an anecdotal fact. It's actually in the literature. But those academicians who just want to put aside anything that they don't like and they just call it anecdotal, it's not just unfair. It is not effective to do that. But I'm all for science. We have a study. And if you contact me, I'll send you a copy of the study. Next up is dental schools that I have been made aware of. I was not aware. I came through dental school quite some time ago, finished dental school in 1973. TMD was addressed very slightly, but recently I've been made aware of several dental schools that have taken up the challenge of treating TMD. But what I've learned about those programs is that what they want to do is that they want to literally pad the other services within the university and spread this problem of TMD around to other services whose service really has nothing to do with treating TMD. By getting multiple complicated radiologic examinations, you do not need an MRI or a CT scan to properly diagnose TMD. You need an X-ray. You don't want to miss something, like a cyst or a tumor, whatever, but that can be done on a simple X-ray, on a simple panoramic X-ray. You don't need to send the patient off to thousands of dollars of radiographic treatment, psychiatric and psychological treatment. That's, I mentioned that before. We know we're all stressed. There's not a person on this planet who is not stressed. We know the only thing we know about bruxism, it is related to stress. The more stress, the more bruxism. We do not understand the mechanism. There is no on and off switch. no matter what you are told or what information is given you. There is no on and off switch about bruxism, but people are stressed. The more stressed they brux, but no matter how much you brux or how stressed you are, if you get rid of the inflammation, it makes no difference what your psychologic or psychiatric level of treatment is. So it's frankly useless. It's sending a patient around for a service that is not only not effective, but doesn't come into play. Physical therapy is another. Physical therapy has a great value in post-surgical treatment and getting someone back up to normal duties after surgery or after an injury. But physical therapy to treat inflammation within the joint is not going to be effective. You're only treating, physical therapy is range of motion, it is muscle use. If you make the inflammation go away, the muscles quit getting tight and you do not have any more pain. This has been noted many times throughout these episodes, but that's the simplicity. What did I learn? I learned that many of the other modalities of treatment are superfluous and continue to be used constantly. So I'm confronting it. I'm trying to stir up a few criticisms, if you will, because I'll back up what I have to say. Textbooks. I just opened up one of my old textbooks on TMD, and just to kind of refresh myself about what has been published in a well-respected, well-authored textbook. And basically what I found is that the textbooks on TMD are nothing more, nothing less than a compilation of the different studies that have been noted. And so it goes from page to page. This author basically says this about this modality, and the next author, and this study shows this, and then the next study and this author shows that. And so a textbook on TMD is nothing more than a compilation of the studies, and I already told you what I think about the studies. The more studies, the less they know. But that is what's in the textbook, besides the anatomy. I mean, the diagrams of the anatomy, and basically basic physiology, basic neuroanatomy, neurophysiology. That is valid information and very good information and very needed information out of a textbook. But a compilation of all the studies that were done about TMD, most of them in disagreement with one another, is really of no value or not much value. Just to comment on the myofascial theory, and my note here is myofascial theory. Myofascial pain is a theory. It is noted as a theory. When you read up on myofascial pain, it is well noted that it is not understood. It does have something to do with trigger points, which are nothing more than tight areas of the muscle. But the myofascial pain is a theory and nothing more, nothing less. And again, it relates back to don't believe everything you think, and make facts count again. This can be everything that I noted within this episode so far can be emphasized to the highest degree by what insurance companies have to say or what they actually do about TMD. Basically, insurance companies don't want anything to do with TMD. They don't want to cover it. They don't want you to cover it. They want nothing to do with it. Why? Because however they came up with their decision, they know that it's a deep hole, and the more you go down that rabbit hole, the less you get. And insurance companies are in the business of making a profit. And they're not in the business of seeing how many people they can help. They're in the business of making a profit. And the more TMD patients they take on, the less profit they're going to have. So they do not want anything to do with treating TMD, truly. And I can talk about my experience there, which would probably take half of an episode. But I can promise you the TMD is not on their list of things that they want to cover or do or get involved with. So ultimately, patients, then that's what we're here to serve. We're here to serve patients. How can we help these folks? That's why I decided to quit surgery and to see if I could figure it out so I could help the patients. Well, patients don't know what to believe. They don't know where to go. And they get involved with some terrible things. I had a patient, again, yesterday who told me her story. She had 2 neurosurgical procedures, which for something called the Chiari malformation. I have talked about this before, but this is a different, separate patient who I talked to yesterday. Because she had a chronic recurring headache and pain in her neck, she was diagnosed by a surgeon who I won't even name the city, but it was not in Tennessee, that she had a Chiari malformation, which is penetration of parts of the brain or brain stem or cerebellum through the foramen magnum. And that is a real reality. That malformation can cause head pain. But this particular patient, by her history and her examination in my office, and what she told me, these 2 surgeries were done 20 years ago, and she was still having headaches, jaw pain, shoulder pain. But she had 2 neurosurgical procedures for Chiari malformation, which were not effective. And the last surgery, basically the surgeon felt he had to cauterize the cerebellum or part of the cerebellum, and now the patient has problems walking. Those are the patients that your heart goes out to, your heart bleeds. You just, if that patient had been addressed prior with a simple device that unloaded the temporomandibular joint, allowing the inflammation to die down, she would have never been looking for a solution ending up in the hands of a neurosurgeon to do a Chiari malformation surgical procedure. And then finally, the doctors don't know what to believe and where to go. And that is why it's important when you do have a solution that you make your colleagues in your particular area aware that you have that solution. They're not going to find you automatically. They're going to misdiagnose it and go on, like I mentioned before. They're just going to go on and misdiagnose it and think it's something else. And that's what we're trying to solve. And we have that solution also, is basically how to make doctors aware of this. And I've discussed that in other episodes. Our little marketing program, snail mail letters out to the doctors. Basically, once the patient is coming up the line with 50%, 70%, 90% of their symptoms diminished or gone, they each get a letter. Each of those prior doctors, get a letter stating your patient with symptoms, these particular symptoms, that you had seen. One of your patients is now 70%, 90%, 100% symptom-free, and then they actually kind of wise up and begin looking for TMD rather than whatever they called it before. The most common is migraines. So don't believe everything you think. I certainly was at fault. I admit it. And facts make facts count again. And facts can be anecdotal, but peer-reviewed science is the gold standard, fully admitted. So anyone would like a copy of our independent university studies, happy to send you a copy. For that, I think I'm just going to wrap it up. I would invite you to learn more about what we know, what I know, how to use the Urbanic device and protocol. All you're doing, it's not the device itself. All you're doing is unloading the temporomandibular joint long enough to allow the inflammation to decrease. And inflammation does not decrease overnight. Sometimes it takes several weeks, sometimes it takes several months. Each of those symptoms goes down at a different rate. They all don't go down simultaneously, but they go down when you unload the joint and allow the inflammation to decrease. If you'd like to learn more, our website is www.tmjservices.net. If you want to criticize, you want to comment, or you want to say that a boy, I can be reached at Tony@tmjservices.net. Our director of marketing is Naomi at Naomi@tmjservices.net. Until next time, I look forward to speaking with you again. I am Tony Urbanic, and this is TMD Demystified.